Welcome. I'm Rebecca Brendel, Director of the Center for Bioethics at Harvard Medical School. I'll be your moderator today for this critical and timely discussion on trust and ethics in public health. Joining me today are David Augustin Hodge, the Interim Director and Associate Professor of the National Center for Bioethics in Research and Healthcare at Tuskegee University, Evelynn Hammonds, Barbara Gutmann Rosenkrantz Professor of the History of Science and Professor of African and African American Studies at Harvard University, and Professor of Social and Behavioral Sciences at the Harvard Chan School of Public Health, and Allan Brandt, Professor of the History of Science and Amalie Moses Kass Professor of the History of Medicine at Harvard University. Thank you all for being here. I want to start with some important framing for our audience, some of whom may be learning this material for the first time. It goes back to 1978, well, actually before, but we'll put ourselves in 1978, after 4 years of work. A National Commission of Physicians, Lawyers, and Scientists released what is now known as the Belmont Report, laying out ethical principles for research with human participants. One catalyst for this work was the revelation that for more than 40 years, the United States Public Health Service and the CDC had conducted a study in which researchers observed the effects of untreated syphilis in nearly 400 African American men. This, despite the easy availability of medicine to treat them. The men who were enticed to participate in the study with the promise of free medical care were never informed of their diagnosis. By the time the study was shut down in 1972, more than 100 patients had died of syphilis or its complications, and dozens of their wives became infected. 19 children were born with congenital syphilis. Now, close to 5 decades after the Belmont Report was published, it's time to look back at what it has meant for ethics and trust in public health and medicine, and to consider the work that's still left to do. David, you've been spending a lot of time thinking about research ethics and healthcare ethics, and you've been working to create a Tuskegee response to the Belmont Report. Tell us what that means and what it's all about.
Good afternoon, everyone. Good afternoon, family, and it's just so good to be here. Thank you, Becca. Thank you, Amalie, and all of those who work together to make this opportunity possible so we can have a conversation on this very amazing question. The Belmont Report did and was supposed to do a remarkable job in responding to not just those men in the syphilis study, but in terms of research, in terms of human subjects and how they should be cared for and cared about. That was its responsibility. Here we are 50 years later, and we see that excess deaths categories are still ruled by the same pigmentation of those who were in the syphilis study. Black men and black people are still dying at a faster rate in every one of the excess deaths categories. And so we have to wonder to what extent the Belmont Report, as excellent as a project it was, doesn't it need to be interrogated to ensure that we get closer to where we need to be? In clinical trials, for example, we still have low participation. And though there's low participation, I am really wondering, are the factors or the actions that are being done to increase participation in clinical trials, are they considering all of the nuances that may be involved in why many will not be participatory? So even though good actions are present, one wonders whether or not those good actions are missing some critical points, like what kind of access are present for the good actions. For example, if we want to do critical trials with people who live in rural communities, and a large population of black people in particular live in rural communities, if you want to do clinical trials, have we given due consideration to what access means? Like access to transportation, access to childcare, access to food and food securities. So these are stuff that they deal with on a regular basis. So if there's no access, then to what extent can we say that the action is legitimate. So we have to raise questions about the kinds of things that undergird what we think is good morality in access. So we know about the social political of health, we know about political determinants of health, and my dear brother Lachlan right here, I've been talking for quite a bit on moral determinants of health. To what extent are we serious about the moral determinants? So the Tuskegee report is what I would call a black bioethics approach to interrogate the Belmont report to see to what extent the factors and the features in the Belmont report are consistent with the kinds of things we need to be considering. For example, one of the most major parts of the Belmont report is justice, right? Justice is important. Justice is major. However, justice is quite abstract. When have we ever achieved justice? What does justice look like? Now, if we talk about social justice, we could actually put some measuring on it. We could level the field somewhat, because we could actually look at pieces and see how critical they are. For example, if there's only a Piggly Wiggly in Macon County, and that Piggly Wiggly represents the best of the fruits and vegetables that you're going to get, how then can you support your children and give them a healthy diet? Now, the strange thing is that right up the street in Auburn or down the street in Montgomery, which is about 15, 20 minutes miles in each direction, you have Kroger, you have Publix, you have all of these different places. But now you have transportation as an issue again, and you have funds. There's no city bus that runs in rural communities. So now we're struggling. So the Tuskegee report then is the National Center's attempt to respond to the Belmont report with practical ideologies, practical thought, to really interrogate what we need to do to ensure that we can have a better playing ground.
So there's a lot to unpack there, but really what you're suggesting is that we need to look from the perspective of a black bioethics, from those who have been systematically left out, even after we've made moral commitments in the Belmont Report 50 years later to really respond and to ensure that that didn't happen again. Evelynn, I'm wondering if you can put this in context for us about what that looks like in terms of health disparities, thinking about, for example, black maternal morbidity, mortality crisis, and how this all fits together to where we find ourselves today.
Well, first, thank you all for inviting me, and I'm happy to be here on this panel with people I have a great deal of respect for and the work that they do all the time. So the answer to that question is a very long one historically. I mean, the way I put it is that we've not had a time since Africans were first brought here and became enslaved in the United States. We've never had a period of time when there weren't health disparities. And the distinction between, what was health for those who were enslaved versus the health of those who enslaved them is something that began to be noticed as early as the first time black people arrived here as slaves. So we have to think about it's been a long story. In that sense, that means that there are ways in which we've accepted in this society that there will be health disparities. And so certainly for me and those of us who've studied African American history, and my colleagues here on the panel, what happened in Tuskegee, and that the Belmont Report is a response to, was something that we have been struggling with in this country through public health infrastructure as well as the medical establishment to try to address. But certainly Tuskegee became this sort of flashpoint of bringing all of what we have been aware of in the past to the fore. And so one of the major issues, as David just talked about, certainly was issues of access that, certainly deserved much more extensive discussion than what occurred in the Belmont Report. Secondly, the ways in which we want to talk about not just what happens to individuals, but what was happening to Black communities throughout this long history. And of course, this period of time, 1619 to the present, is a long period of time. Many, many things have changed. But there are some aspects that I think are persistent across time. And the one that I would point to is, if you think about the Black maternal and morbidity crisis as it's now defined, one of the first things I said about it when it was first called a crisis, I said, how long? It's been going on for like 2.5 centuries. Why is it a crisis now? I mean, it's always been a crisis. And so, but one of the things that reproductive health advocates and scholars have been writing about is that something seems to have made this crisis, this situation, into a crisis in the late 20th century for some observers. And one of the issues that has emerged from that is how to determine what is the cause of it. And that's where the health disparities work is coming in. How do we figure out what causes it? And there rooms full of studies trying to figure this out. But I think there's something very important here that we do take this time right now to try to figure it out. I hopefully once and for all come to terms with the kinds of factors that have led to high rates of Black women's death and their infants' deaths as well. That we can really begin to make a shift in the ways in which it's both at the individual level, it's at the community level, and it's at the level of systems and institutions in this country. I think we can mark all those things, but we still haven't been able to come up with a coherent story. And back to the point of access, one of the things we do know, if you just think about trying to understand this crisis in terms of race, you get up to a point, you get some clear factors, but then if you add socioeconomic class, then you get other issues come up. And so one of the consistent things that have recently been discussed is many Black women, no matter their educational level, no matter their class status, are still reporting that they are engaged, they have to deal with health practitioners who do not listen to them. The story that Linda Villarosa told in the New York Times article about this crisis, she's talking to someone like Serena Williams who's saying, I tried to tell them that something wasn't going right with my pregnancy. Why isn't anybody listening to me? But that's what many generations of Black women have been saying. Nobody was listening to me about what was happening during my pregnancy. And that inability to listen and understand that is something that clearly is a major factor, at least from the perspective of Black women, into why we have this crisis today. So we have to look at this long history. It's multifactorial. It's complicated. But then again, some days I just say, it's not that complicated if you just say, why aren't we listening to people? Why aren't we paying attention to these voices? And what does that mean?
Well, there's so much there to guide us in this conversation. Lots of history, lots of some attempts to try to make things better. Certainly the Belmont Report was one of those, right, to try to figure out how can we end these disparities, how can we make treatment and interventions work for all persons. And yet, as you tell us, we've really still fallen short of that ideal. Maybe from this day forward, we can make that different, let's hope. But one of the themes that really stands out is here's this system that's made bold attempts with Belmont, that's tried in many ways, at least in coming up with data about morbidity and mortality and trying to look at disparate outcomes. And yet still, our systems or the results haven't been good. And it brings up major themes here about trust and trustworthiness, right? So when we talk about vaccines, when we talk about maternal morbidity and mortality, sometimes we say, well, people aren't trusting the system. But in many cases, as we're hearing, the system really hasn't earned trust. And so it becomes a problem of priority. I guess, Allan, maybe you could shed some light for us on some of those structural and systemic factors that either support or undermine trust.
Thanks, Becca. There's one thing that's really important here about the Belmont Report. The Belmont Report, I would say, intentionally avoided issues of access and disparities in health of populations. The Belmont Report's principal focus was on human subjects research.
Right.
How should we do that? You know, should people have informed consent, which of course the men in Tuskegee did not have. They were lied to. But it really was very clear not to raise broader issues about the healthcare system. And so the principles that they laid out were respect for persons, you know, led to a revolution in informed consent in experimental situations, not necessarily in clinical situations, what they called beneficence, which really focused on if you're going to be in a human experiment, the benefits of being in that experiment really have to outweigh the risks. You have to have an intention to try to assist somebody with a disease or a new treatment that hasn't been explored. And finally, they said justice. And I think most of us read that like, well, the Belmont Report was a clarion call for justice. But the Belmont Report really meant justice by we should protect vulnerable populations from exploitative research, i.e. Tuskegee, but that if we focused our research on vulnerable populations, that could create an injustice like Tuskegee. And they were very scrupulous. We're talking about research. We're not talking about patient care. We're talking about investigation. We're not talking about clinical therapeutics and ethics between an individual patient and their physician, if they had one. So I think that's important because it's a structural intervention in which the assumptions of what it was likely to accomplish have often been grander than its real focus. And I think there are a lot of these structural issues. One of the first papers I wrote was about the Tuskegee study. And sometimes I check to see if anybody ever read it or is still reading it. It's actually the most read paper I've ever had. And people would ask me, like, why haven't we solved this? Why didn't we do better? And in part, it's because as valuable as the Belmont Report might be in some ways, it was focused not to address these questions. And I think it was just too politically difficult for them to really address questions of racism, of health disparities, of access to care, of access not just to care, but to high quality care for everybody. And that would have been politically disastrous, I think. And so, you know, did they get the best they could? I'm not sure about that at all. But it was in that moment. And I think this is one of the reasons why we have sort of what I would call structural mistrust. Because the expectations were with the new bioethics, we would really begin to address these questions of fundamental inequity in health in our society. And the reason people still ask me about Tuskegee is we never solved those problems. We didn't come close. And in many instances, it got worse. So Tuskegee remains a powerful symbol of our failures of ethics, morals, and the fundamental aspect of distrust. If you don't solve the problem, you're going to continue to have this kind of very serious mistrust.
Can I jump in?
Absolutely.
So Allan, do you think, you know, we do read your paper, we do still teach your paper, it's still wonderful. So one of the things that flip to protectionism over confronting structural inequities, do you think that's really the key, one of the key failures?
Well, I mean, we see this, and you know, I think that the ethic of the Belmont Report was actually, how do you solve the problem of Tuskegee? You don't recruit, you know, men who are non-literate into a investigation. So what they saw the failure as really being is we had exploited a vulnerable population. Yes. And it led to more research being done on middle-class white people and really restricting access to experimental therapies and research to the African American community and other, so-called vulnerable communities. And as things really changed, many of us today are advocated to seek a drug trial or a clinical trial when we're ill. And many people do now benefit in those clinical trials, but it was both, I don't want to be in a trial and I can't even get in one if I wanted to. And our views of trials have really changed since, almost 50 years now. Trials are again an aspect of equality of access. And so I think that we see the sort of historical residue of the Belmont Report. If people have equal access to care, they should also have equal access to research opportunities that could benefit them.
Well, and certainly that legacy has gone forward, but perhaps what we're thinking about is some of the very questions about what defines vulnerability in the first place, right?
Yes.
I mean, if you have a system and structures that favor the voices or deprioritize the voices and lives of some versus others, then you can say, well, maybe there are limits to how we do that, but it doesn't give you a positive account of how we might do differently or how we might actually change that, right? So it asks questions around the margins in sometimes very abstract terms, which has been one of the, amongst historians, one of the big challenges that has been levied around bioethics as a field itself, about being so involved in these principles and ignoring or not paying adequate attention, at least, to the lives that they affect. But we'll come back to that. We have a lot to talk about. I think as we think about this, it's hard not to think about the COVID-19 pandemic in the context of all of the structural and systemic issues, as well as the particular questions about health and about research. But I think one thing that COVID-19 pandemic is illustrative of for us is that it really laid bare the incredible health disparities that we have in this country, with Black Americans having a mortality rate that far exceeded, even doubled population share from COVID-19, and really the resources that weren't available. But maybe, Allan, you could tell us a little bit more about how COVID-19 amplified some of the issues you're talking about post-Belmont, and then maybe, David, we could take that back down to the experiences you had at Tuskegee and in the community.
Yeah, I would just start by saying, I was in meetings here at the School of Public Health in early 2020, and I think many of us who are public health people felt that this was going to be it would be terrible. It's a global pandemic, but at the same time, this would be a chance to demonstrate the efficacy and the intelligence and the ethics of public health, and that public health was on the stage again and being called on to help mediate the pandemic. And I have to say, now in 2025, I really feel that the pandemic harmed public health in very powerful and important ways. There are ways we're going to be studying and having to respond to. But the idea that public health could present a clear message, help us through the pandemic, that it would rely on, the best evidence. And one of the things we learned is just how hard pandemics are, and how much, people with authority are making, immediate decisions with inadequate information. But that said, given the politicization of the pandemic, these are really challenging times for public health, for schools of public health, for their legitimacy and authority in speaking to the public. And I think it exacerbates, long historical failures of policy and practice that are also something we have to address. So I'm following the crisis of public health and academic medicine very carefully, and I think one of the questions we want to ask, and I wish I had better answers, is how from where we are now do you recover the trust and respect to be able to lead in both in healthcare crises, but also in returning to the agenda of health equity, excellence in delivery, the idea that sometimes the state can make requirements of individuals in dangerous times. And as I watch the delegitimation of vaccination to, well, you should decide whether you want to take it or not, we see how denigrated public health and public health authority has become. So these are such immediate and powerful issues, I think, for all of us to be thinking about.
Yeah, that sets a really helpful context, right? On the one hand, there's a way in which this crisis really laid bare what, on some level, many of us already knew, but just showed it. And yet, on another, because it's a crisis, it's so hard to respond to, that it brings out not always the best of our ability to respond and demonstrate how we could do better.
Yeah. I would just quickly say, the bioethics of the Belmont Report actually are part of the erosion of public health. Because if you're told, like, well, we have a new vaccine, you should take it if you want and get informed consent, then bioethics itself structurally has eroded some of the authority that's needed to really deal with the pandemic. So, there are these ironies here, and, I would say the focus on autonomy in bioethics has hurt the notion of what we owe each other and how communities can respond to disease.
So for me, I think we have been focusing on the erosion of public health, trust in public health. I don't think we ever had a great deal of trust in public health in the first place. I don't know what there are parts that I think are manifestly being eroded in that we had high rates of vaccination for childhood infectious diseases, which my first book is about the control of diphtheria, which was controlled by the development of vaccines and immunization. And so, but even at that moment in the early 20th century, you couldn't say there was universal trust in what the public health experts were saying happened, but that trust built over time as those childhood infectious diseases came down to the point where people just assumed didn't even matter anymore. I mean, when I was growing up, if people had measles, it was like, oh, so boom, everybody knew what to do. There weren't these huge flare-ups that we have now. But I don't think that meant we had trust. We had trust in the role of vaccines, but I think there are other places in public health that weren't as trusted. And therefore, I think some of those places are now bigger and more visible problems than before, that maybe we had gotten used to using the success of vaccines as a way to suggest we had trust in all of it. And we did not. And I think also we become used to a fragmented public health system that didn't serve all the needs of all the people in certain kinds of ways. And if we became used to seeing that as normal, that fragmentation, then of course as different parts of this become more visible and easily attacked, as what happened, I think, in COVID, then it unsettles the whole system, because it was never coherent, fixed, established system in the first place. So I do think there's erosion, but I think we ought to be clear about what was trusted and what wasn't trusted, and what that meant to regular people. I think we've gotten to the point where we normalize the fragmentation, the disparities became normalized. And the acceptance that, yeah, we've always had health disparities and probably always going to have them. But no, we lost that sense of that, no, we shouldn't always have them. And why don't we have that sense of urgency to fix it now? And then when the crisis came in COVID, wow, that made it really clear that we had not been fixing certain kinds of things.
Well, I'm going to come back to you. So let me try to pull a couple different threads together, because I think there's a couple things that maybe we can bring to this. Number one is, and I think, David, I'm going to put it on you in some ways, because you've been pushing us with the National Center to be thinking about bioethics not as these abstract principles that are about individuals, but really what about ethics in public health, with the public health ethics intensive that you do, and thinking about what our community commitments ought to be. So I want maybe you to take us in that direction before we come back to this idea that in some ways we got what we asked for with the Belmont Report, in some sense. When we think about these inchoate or really abstract ideas about justice, we're going to end up with exactly that, loosey-goosey. What are our metrics? How do we measure accountability, and how do we get to where we actually thought we needed to go, but either couldn't find a way to say, or were too afraid to say that because of the pressures and some of the challenges there. So let me hand it to you, because you can say this a lot better than I can, and this is so much of what your life's work has been about.
Thank you so much. I heard so much. Thank you so much. You framed the context really well, so well in fact, as to show why you have really affirmed why I think I'm on the right track. And that is that the Belmont Report as a attempt to deal with human subject research 50 years later. You didn't know 25 years ago that it was on the undergirding strand of what you're trying to do was forgetting about the vulnerable populations, because excess deaths continued to grow in massive numbers. Vulnerability continued, populations continue to die. I think so the Tuskegee report is saying, no, Belmont, if you are going to persist in that, well, good luck. Continue to do what you do, but there has to be a vision of what it looks like to help other people where they are. And that is what's critical. Research is great and necessary, but if it doesn't get to the least, the lost, and the left out, if it doesn't get to a 13-year-old girl in Kenya whom I do not know, or a 13-year-old boy in the Palestinian region, or a 15-year-old boy in Venezuela, somebody whom we do not know, then we're just talking. The Belmont Report, it should have done one thing particularly, and that is show we are great in terms of doing research. We're not so great, just as you said, in attacking the clinical side of where people are hurting. For example, let me state what Black bioethics is before I say anything else, because Black bioethics is kind of misleading. Because assumption, when you hear black, you hear pigmentation, right? You're talking about black folk and whatever black folk do. There's something that came out in 1968. It's called Black theology. Black theology was an opportunity to have a conversation about the things that mattered to a group of people who were being neglected. For example, from 1867, 1868, we've been having HBCUs. Right? We've had historically black colleges and universities. We've had black churches. Why do we have black churches? Why do we have black universities? Because black folk were told that you can't come here. You are not welcome here. This is not a place for you. And now that they're thriving and black young folk are getting trained and educated and so on, then black folk are said, we're told, well, you don't need them anymore, and you will not be supported in your endeavors. Have you ever thought that at least 90% of everyone called doctor in America came through a HBCU? Did you know that? Especially your president Spelman was one who put that up very nicely.
Yes.
That over 90%, because they call me doctor. right? They called me doctor twice. And I went to American Baptist College, the same school where John Lewis graduated from, and C.T. Vivian, and received presidential the Medals of Freedom. I went to a little black school. We tried hard to have 150 students. We never achieved that goal while I was there. And the thing that's most interesting about that is Harvard would not have accepted me, so I didn't even apply, right? As a matter of fact, most schools wouldn't have accepted me anyway. But nevertheless, what HBCUs do is they take the least, the lost, the left out, those who are forgotten populations, those who were raised in inner city schools, those who lack access and provide access, and then say, go out there. We had a student just now that's finishing up right now. We just talked about him with Bianca, and she finished at Tuskegee University, and now she's finishing at Harvard, Center for Bioethics program in a master's degree. So this is the kind of conversation that we need to be having. That the Belmont Report, yes, you're doing a great thing, but the Tuskegee Report needs to be focused on human beings, not just on autonomy, but on agency. Right? Not just a self-government, but a governance, but a self-choice, and what it means to make choices. No. But what does black bioethics mean? Let me say this. I said black theology is about black protests, right? It's about protests against a system. Now, during the 60s and the 70s, black theology or liberation theology is what gave rise to feminist theology and gay theology and all of the margins folk. And that's what black theology has been principled for. It's about protests. I would not be so foolish as to suggest black bioethics if it excludes the least, the lost, and the left out. Why? Because black theology and black bioethics is about focusing on people who cannot speak for themselves. Therefore, my brand of black bioethics, repurposing the word black, not in terms of pigmentation, but in terms of identification, my brand is about protest. Because if I'm sitting in the National Center for Bioethics and Research and Healthcare at Tuskegee University, the National Center, and I'm talking only about black health, that is ridiculous, uninformed, unintelligent, and disastrous to my dear brothers and sisters who are right now on the southern border of the United States, locked away. Do we ever wonder when you see the news reports of these brothers and sisters on the southern border and in these little makeshift prisons? Do you ever wonder, like, how do they get water? Are they getting 3 square meals? Where are their children? I know if my son if my son called me right now, meeting is over, right? The session is done. If my children call, it's all over because my children are my priority. What happens to those kids? That means somebody needs to be concerned about them. What about the over 1,000 Native American women from Oklahoma all the way up to Alaska that have gone missing over the last couple of years? Who is concerned about those? Wait a minute. What about the methamphetamines that's killing the poor whites in Appalachian Mountains? Who's protesting for them? Viola Luiso, she wasn't a black woman, she was a white woman. She came down south to help drive folk around. Reverend James Reeb, he was not a black man, he was a white Presbyterian minister. He got hit in his head with a rock and he was murdered. Viola Luiso was shot. Gutmann and Shorter and the friend Cheney, they were all killed in Mississippi. These people are black to the bone. It's just like they're white in the skin. So it's not about pigmentation. It's about how do you identify with the least, the lost, and the left out. That's what I'm framing. Now, having said that, now I come back to answer your question with respect to trust. I was holding it in. All right, now I come back to respond to that, to the question about when you said, Allan, when you used the word to recover. But I'm not going to say much about that because my dear sister Evelynn came and she actually responded. Because we don't want anything recovered. Black, brown people or people on the opposite side of hard want nothing recovered. Make America great again, that's a nice slogan, but pick the year. Pick the year that I would want to go back to. Somebody asked my son, Dad, where would you like to be, in the past or the future? Boy, don't ask me stupid questions. There's nothing about there that I want to go back to. There's the only place I want to go forward, because in the future, you know what's going in the future? Young people. And one thing you must love about young people, they have friends that look like other. See, as old people, we got to get off the stage. Look at who comes to your Christmas party, your Thanksgiving dinner. Everyone at the table look like you, look like me. But our kids, They have friends that looks like other. And that is what's most potent for me. And that is how we must now start thinking in terms of trustworthiness. I cannot continue to trust a system that lacks trustworthiness. Well, what is trustworthiness? Trustworthiness is a value. It is a virtue. Trustworthiness is something that you can actually do. See, trust, you don't have any choice. You wake up in the morning, you got to trust. You got to trust that the air is good. You got to trust that the floor is there when you step off. You got to trust. It's just part of who we are to be people who exist. But what it means to be trustworthy, it means that people got to put in the work. Trustworthiness means that I have to make up my mind not to treat somebody as though they're not an other or be other regarding. So I'll pause there. Did I answer your question?
And then some. That's great. That brings us to one of the questions that came from one of the viewers in advance, from Joy Jubino at Western Illinois University, because she asked a really poignant question, which is that we're focusing on the past. Are we missing out on mistakes of the present? Or maybe I'd modify that question a little bit and say, what ought we to be looking at now in the present that can then direct us to the future that you're talking about?
Can I go first?
Yes, of
Okay,
course.
good. So I can finish what I had to say.
It'll give everybody else some
Thank you.
time to think.
Okay, yeah. Here's what we got to focus on for the future. Listen, we're already seeing things getting murky. There will be another pandemic, right? It's coming. A pandemic is coming. When the last one came, did you ever stop to think that down in Albany, Georgia, there were more black folk dying from the pandemic? Anderson Cooper went down there and he said, this is criminal that so many black people died from the pandemic. How does COVID know to go after black people? How does it? When did they get that memo? We need to go after black people. That's like how do tornadoes in the Midwest know to go after trailer parks? Right? How does it know to go after these particulars? Well, what was happening in Albany was comorbidities. So if you have a morbidity, like I'm diabetic, so I have a comorbidity too. I'm hypertensive. I have another one. I'm chubby, right? So I have these comorbidities. Therefore, when pandemic strikes, I'm on the top of the list. I was able to escape. So if you live in a community where there are these morbidities and comorbidities, you're vulnerable by definition. Therefore, public health today must make darn sure to focus on the least, the lost, and the left out to resolve these morbidities so that in the next epidemic, we will be ready. Otherwise, you'll see more black and brown death because the simple weren't ready because public health was not seriously interested.
All right, so where do we go?
I think it's a really tough time. And, when I talk about recovering trust, it really is about, how does public health be perceived as trustworthy again, and how do you earn that? And so I found myself thinking in anticipation of this discussion today, in a way it would be great for public health to really explain itself more clearly to a mass public. And I don't think people understand public health, and they have different connections with it, many of them highly negative. So the public health officer is just next to the police officer. So it's coming in to take somebody's blood, find out who needs to be quarantined. And so I think there really is a different ethic of public health, and that we have some responsibility to try to articulate it now in the broadest sense. And, we haven't communicated well, and we have mostly communicated with one another. And it is really time to have a new kind of manifesto, and it's not the Belmont Report, it would be, some other report,
the
and it
Tuskegee
would
report.
really draw together, broad thinking, both in the technical skills of public health, But what we sort of know is public health's been deeply committed for decades to reducing health disparities and studying them. But we haven't really communicated to our many publics, what it is we do, how we try to do it, the difficulty of making decisions in the face of really powerful uncertainties that we, people say follow the science, but in a pandemic, there often is no science. And so what are the values and ethics and moral commitments to health equity that informs what we do? That's the first thing. The second thing is we have to end this boundary between medicine, science, and public health. It doesn't mean anything anymore. Physicians want to help populations. One of the ways we get better health is serving individuals, and the traditional boundary between public health and medicine really needs to be, absolutely rejected. So those are the two big things, but I don't know how to fill in many of the details.
That's great.
I like to think about the past and the present. I like to think that in the early days of the next one, that those in public health and medicine and in research science would say, what is it we know and what is it we don't know? And who are we paying attention to and who are we not paying attention to? Because if the past tells us something, there are the people there who you already know, and I love this phrasing, who are the least, the lost, and the left out. We know who those people are already. So why not start with saying we know that exists and we need to go there as part of our, before we say another word, what that means. And I can remember when I was taking Allan's history of epidemiology class when I was a graduate student, I remember going to this meeting. I think we were at one of the hospitals, and I just wanted to come and see what they were going to say about HIV, and but one of the things that was really clear to me, the people who were running through my mind that I was going to be worried about, certainly starting with my family and friends and all these kinds of folks, that wasn't on the table. But this is what I mean. That has to be on the table at the very first moment. Not, oh, whoops, we forgot that population. No, we can't. We know we cannot do that anymore. It may sound simplistic to put it that way, but I do think what the past tells us, there are some fault lines here. There have always been fault lines, and they are structural fault lines in how we respond. And so let's start with the fault lines before we immediately think that we have to privilege the science. We know some things, and we ought to start with what we know and the problems with what we know. And therefore, what we've said in post hoc examinations of some moments, we failed morally and we failed ethically. We know what those moral and ethical failures came from. So let's start with them next time, COVID 25,000, and see what we can do if we look at it from that vantage point first.
Or even better than that, not let us get to ourselves to the next pandemic before we really push forward with capturing our values that come together. Right? If we can figure out what we agree upon and what ought to be important, then maybe we can figure out how to align our science, our medicine, and our public health with the values that we all hold as humans and our responsibilities to each other. So we're going to end on a very positive note, having gotten through only scratching the surface of what we had, what we hope to talk about now and into the future. And I really want to thank my colleagues for this incredibly thoughtful conversation. And to remind all of you that if you missed any part of the program, you'll be able to view it on demand on the Harvard Chan School's YouTube channel. Thank you so much for being with us, and have a wonderful afternoon.
Thank you. Thank you. Thank you.
That's great.